Protocol 26 is our head injury protocol. There are a few parameters here and some treatment to prevent or hopefully help brain herniation syndrome. Okay, so in our head injury patients, of course, we never hyperventilate our patients. We're just increasing ventilations when indicated. Now, in our normal patients, the adults are bagged at 8 to 10 breaths a minute, pediatric patients at 12 to 20 breaths a minute, and infants at 20 to 25 breaths a minute. And we maintain a normal end tidal of 35 to 45 millimeters of mercury. In our patients with brain herniation syndrome, which is indicated by unilateral or bilateral dilation of the pupils, and posturing, decorticate or decerebrate, we want to increase our ventilations for adults 14 to 16 breaths a minute, pediatric patients 20 to 25 breaths a minute, and infants 25 to 30 breaths a minute, so we can maintain a low end tidal reading of 30 to 35 millimeters of mercury. Now, also, increased intracranial pressure may cause what we call Cushing's reflex, which is hypertension, bradycardia, and erratic respirations. This is also an indication of a brain herniation syndrome. So why do we increase ventilations in brain herniation syndrome? Well, by increasing ventilations, we decrease carbon dioxide. Carbon dioxide dilates the cerebral blood vessels. This increases the blood volume in the intracranial vault and therefore increases the intracranial pressure. Of course, just a reminder, we are increasing ventilations. We are not hyperventilating our patients. Hyperventilation must be avoided. Okay, Protocol 27, our multi-system trauma protocol. No real changes here from your current treatment. Of course, our advanced providers are going to focus on fluid resuscitation if indicated. That fluid resuscitation is a normal saline bolus of 500 milliliters, IV or IO, and you may repeat to maintain or obtain peripheral pulses. Protocol 28 is our abdominal pain protocol, and for our advanced providers, your antiemetic of choice is still Zofran or ondansetron at 4 milligrams IV IO. Just some notes on abdominal pain. Abdominal pain in women of childbearing age should be treated as pregnancy-related until proven otherwise. The diagnosis of abdominal aneurysm should be considered with abdominal pain in patients over the age of 50 years old. And also, we need to consider cardiac etiology or cardiac being the cause of the pain in patients over 50 years old, diabetics, and or female, especially with upper abdominal complaints. Protocol 29 is our allergic reaction anaphylaxis protocol for adults. Okay, so this protocol is broken down between mild, moderate, and severe reactions. Let's take a look at mild. For our advanced providers, they can treat a mild allergic reaction with Benadryl, 25 to 50 milligrams IV or deep IM. For our moderate reactions, our EMTs should go ahead and treat the patient with the EpiPen if the patient is greater than 30 kilograms, and albuterol nebulized at 2.5 milligrams in 3 mLs. And they may repeat this 3 times as needed, and they can administer that without a patient's prescription. The advanced provider under the moderate reaction should treat the patient with epinephrine 1 to 1,000, 0.3 to 0.5 milligrams IM, and if they have not already done so, administer diphenhydramine or Benadryl at 25 to 50 milligrams IV or deep IM. Okay, so for the severe allergic reaction, the EMT, if they have not already administered the EpiPen, will do so, as well as the albuterol nebulized, and again, no prescription required. The advanced provider, if they haven't already done so, will administer the epinephrine 1 to 1,000, 0.3 to 0.5 milligrams IM, may repeat in 5 minutes one time, and also diphenhydramine at 25 to 50 milligrams IV or deep IM. Protocol 30 is our allergic reaction anaphylaxis pediatric protocol. Okay, for our EMT and our advanced providers in the protocol for pediatric allergic reaction, for moderate and severe reactions, just a reminder that the EpiPen will be administered if the patient is greater than 30 kilograms, the adult EpiPen, and if they are less than 30 kilograms, EpiPen Junior, and those are administered IM. We will also administer albuterol, nebulized, 2.5 milliliters and 3 mLs of normal saline. Repeat as needed, and you can do that 3 times. The altered mental status protocol, Protocol 31, no change from your current protocols. This is really just an assessment tool for you as a provider to determine the cause for the altered mental status. Protocol 32, bradycardia adult, no change from your current treatment of bradycardia for an adult patient. And Protocol 33, bradycardia pediatric, again, no change from your current treatment. I do need to remind you, though, in your assessment, obtain a blood glucose reading on your patient. These pediatric patients can become bradycardic due to hypoglycemia. Protocol 34 is our cardiac chest pain protocol. For all provider levels within these protocols, you will be acquiring a 12-lead ECG. You will be administering aspirin if indicated at 324 milligrams or 481 milligram tablets, chewable, and also administering nitro at 0.4 milligrams for the sublingual tablets. You may repeat that in 5 minutes times 3 as needed with patient-prescribed nitro or BLS drug box. The advanced provider will be also administering the nitroglycerin and also have nitro paste at their disposal. 1 inch of nitro paste, and again, the systolic blood pressure must be above 90 millimeters of mercury to administer nitroglycerin in any form. Normal saline boluses as needed, 250 milliliters at a time, up to 1 liter, to maintain a systolic blood pressure greater than 90. Okay, so let's talk about EKGs. I know this is new to a lot of basic providers and advanced providers. If interpretation presents with acute MI, or STEMI at the top of the 12 lead, or if the EKG is interpreted by an ALS provider to show STEMI, we must begin immediate transportation to a facility that has PCI capabilities. We're going to talk about all this in depth.